So the topics I was asked to cover were, do we use patient-reported outcomes? Are patients involved in treatment, trial treatment? So we're going to cover that. And then I'm going to talk about new treatments, mainly focusing on thyroid disease, but there's quite a lot of overlap. If you can't hear me, will you put your hand up? So, do we use patient-reported outcomes? Actually, yes. MPN is probably the field where we most use patient-reported outcomes in haematology and in oncology, and we have to really thank Ruben Messer for that. But also the fact that many of our newer therapies have really improved patient symptoms. So I can't think of a trial that is currently running that is not including some component of a patient-reported outcome or a symptom assessment. How they are being used, that's another matter. Is 12 months or 6 months enough? That's for discussion. So do patients have input into study design? I think that's another question where we could really do better. My answer would be not as much as they should. In the UK, and I heard from Stefan in Germany, in the academic studies, that means the studies that the community of physicians propose, they go and they get funding for, which is often quite a large amount of money, and they approach the pharma companies to ask, can we use your drug? Sometimes for something a bit different than they might want us to use it for. Then, yes, we do. I also want to give another call out to the American community who actually arranged a meeting with the FDA recently to talk about MPN patients and clinical trials. So it would be good to probably include some discussion about that, Michelle and Bill. So great, but we are not doing it enough in Europe and probably in the rest of the world. So when I think about therapies for PV and ET, specifically thinking about new therapies, we're still stuck with this question, which we touched on about interferon, where we can get it against hydroxyurea. Really, I think we should be reassured that these agents are very equivalent. There are individual toxicities or benefits for different patients, but they seem to be quite equivalent. I think it's fantastic that the Rocaine alpha-2 beta Brasemi has been approved, and there may well be big differences with that therapy compared to hydroxyurea or standard interferon. Certainly a big benefit is tolerability and the ability to space out doses. I want to divert a little bit, and somebody asked me, will we have precision-based medicine? Will we be doing personalised medicine? Well, we recently looked at a so-called academic study in the UK, a bit like Ruxolitinib that is being done in Germany. This is a study called MAGIC. We had all of these bodies all involved in funding the trial. Bloodwise is a different blood cancer charity in the UK. Here we were looking at molecular responses in our PV patients. We saw more partial responses for ruxolitinib versus the control arm. And importantly, we also saw some progressions, but they were roughly the same. We then looked for the first time in a randomized study, so does it really matter if your JAK allele burden goes down? In our sister or brother community CML, it really, really matters if your BCR-ABL level goes down. If your BCR-ABL level doesn't go down by a log at about 3 months, you change your therapy. And this is really something that drives that community. And when we first started using Jak inhibitors, the CML community couldn't understand, why aren't you measuring JAK allele burden? So, we, in this study, have measured the JAK allele burden. We don't expect ruxolitinib to put people into remission, but we did find, in fact, no correlation with whether your allele burden went down and whether your blood count was controlled But we did find that there were no blood clotting or thrombotic events in patients who had a lowering of their allele burden, and there was less progression of the disease to myelofibrosis or AML or MPNs. And the opposite was true. If the allele burden went up, there was a trend to more chance of thrombosis. So this is really important because it's starting to show for the first time something that's, it's logical. If you reduce the amount of disease, you get less side effects. And here is the data for progression-free survival. So it doesn't matter which treatment, just that you get a lowering of your allele burden. Should we all be rushing out now and making sure our patient communities are getting their allele burdens measured? No, because we need to show it in more than just 190 patients in the UK and after more than just 1 year. But this is really interesting and we need to incorporate this into our studies going forward. So, in PV, the target is P53. So I could test you about what was said about P53 earlier on today. I asked John, yes. Isn't that what the teacher does? Ask the people at the back. So P53, effectively, it stimulates the death pathway. So if you have an abnormal cell, it's part of what the body's normal mechanism for getting rid of that. In patients with MF here and PV, there is an increase in this molecule called MDM2, which suppresses P53. So if you reduce this back down to normal, you should have more P53, and in theory you should then be getting rid of disease cells. So we have two molecules, one from a company called Cartos Therapeutics, and another from Roche, who make Pegasus, called Idasanutlin. And the group at Mount Sinai have recently published their early data on this drug in PV patients. Interestingly, Roche thought they might combine it in a clinical trial with interferon, but the other half of Roche forgot that they were not making interferon anymore. Sadly. Also being tested in PV is this agent called Givinostat. It works on the histones, which are important in regulating DNA being active and made into proteins. It also is an anti-inflammatory, anti-programmed cell death, and anti-new blood vessel formation. Sorry, I didn't untechnicalize that. This looks quite active in patients with PV, quite good at controlling pruritus. MPN Voice actually supported a study with a similar compound called Verinostat. It was actually one of the first studies we supported, and we probably picked the wrong dose of that drug. It was a little bit toxic for patients. So this will be coming. And, there's a build in that slide, but it disappeared. Anyway, in the UK and in France, we will be doing another academic study supported by MPN Voice, looking at ruxolitinib earlier in the treatment paradigm. So right now it only gets used second line, so we'll be trying to use it first line. And we'll be, again, asking the question about molecular response. And just to raise the point about patient advocacy and its input, this is what MPN Voice has done for this study. It funds a significant proportion of it. Patients are involved in the design and are sitting on the steering committee and the management committee, and patient-reported outcomes are also included. Nothing so far to say about ET, except actually there are 2 new drugs that will probably be tested in ET shortly. These will come up when we speak about myelofibrosis. One is CPI-610. I'll tell you what it is later. And the other one is IMG 7289. And Martin Ellis and I and others have been trying to bring some of the newer drugs that get used for treating thrombosis forwards into treating patients with MPN to try to do even better to protect against thrombosis. But so far we haven't been very successful, but we're carrying on. Determination is required. So what about in myelofibrosis? So the pressing problem in myelofibrosis is what to do when patients fail ruxolitinib. And I put this slide in because this is the data from the MD Anderson showing that prognosis, if you stop ruxolitinib and you happen to have a low platelet count or a new marker, chromosome or molecular marker, the prognosis is bad. So the current focus is can we have something that patients respond to for longer? Can we have something that picks these patients back up again? Or can we add something to ruxolitinib that means that the response time lasts for longer? We have a new Jak inhibitor called fedratinib. It's not so new, actually. We were testing it a long time ago, but it's now been approved by the FDA. Only the FDA so far. I don't know where Celgene is with filing in Europe or elsewhere. This drug is called Inrebic. Easily rolls off the tongue, that one. This is the structure. It's very similar to ruxolitinib. It's mainly a JAK2 inhibitor. It was halted in clinical development because of a toxicity, probably related to metabolism in the brain, probably not linked to the drug, more linked to the fact that it causes quite a lot of vomiting and nausea. So we have to be monitoring thiamine for our patients on this drug. Otherwise, just this last slide on JAK inhibitors before we jump off and talk about other molecules. The focus currently still very much on pacritinib. So pacritinib, very, very important drug, particularly for our patients who have a low platelet count and myelofibrosis. There's nothing else really conventionally available for those patients. We just completed PAC 203, which was just evaluating again the safety of different doses, and there's a new study being launched called Pacifico. And hot off the press, we were having problems in Europe getting that sorted, so I spoke to the CTI people who were here because the MHRA in the UK said they didn't want us to go to a randomized study. We found a way around that, so that will be available for patients with low platelets. And momelotinib is going to be tested again for anemic patients. Otherwise, then for ruxolitinib and fedratinib, we're asking how can we use them better, combinations, like all of these listed on this slide. Don't worry, I'm not going to talk to you about all of them, but there are many, many, many combination studies being undertaken. Some of them are around how can we better get a patient to allogeneic transplant? Should we use ruxolitinib through the transplant? It's being used afterwards for graft versus host disease. How can we get a better dose for anemic patients? So that's danazol or erythropoietin-like drugs. And then all of these other agents are being used to try to get a deeper response, or they're being used in the second-line setting after a patient has failed. But the problem is, when should we test them and what the endpoints are? And we're still really looking at spleen and symptoms here. So I want to just very briefly in the last 6 minutes talk about non-JAK inhibitors and the different molecules that we are currently looking at, and just particularly picking out 5, but while at the same time also calling out that luspatercept, which has recently been approved in myelodysplasia, which is a similar blood cancer for anemia, looks very, very positive for myelofibrosis. It's really exciting. So, in the past, I've stood in front of you and talked about the ends of shoelaces and telomerase, and it's taken a long time to hear the results of the data with a drug called imetelstat. Recently, this drug has been shown to improve survival in patients who are so-called triple negative. Those are a group of patients who are arguably in the worst prognostic group for myelofibrosis. This drug they recently took to the FDA to go on an accelerated pathway. How further they're going to test it, I'm not sure. Maybe someone else in the room knows. Anti-inflammation. Inflammation is a very hot topic in MPN. This drug, PRM-151, which is an analogue of pentraxin, which has a lot of roles in terms of binding to factors that are important in repairing tissue damage, has been tested. It doesn't look very active, but there are still discussions about how to take this drug forward, and other anti-inflammatory agents. It's a really common question I get asked by patients, and we get on our interactive community about anti-inflammation. A new drug that you may not have heard of before is this one. So this is IMG, I think it was 7289. It is a drug that targets lysine-specific demethylase 1. Effectively, it still works on those beads that the DNA is wound around, but it's very specific for the megakaryocyte or platelet progenitors and red cells. This drug is currently being tested in myelofibrosis. LSD1 is overexpressed in patients with MPN, and so the drug is an inhibitor of that. This is some data that was presented at the European Hematology meeting, and more data, about 40 patients, will be presented as an oral at the ASH meeting. Impressively, in patients who were not doing well on ruxolitinib, this drug on its own did lead to some spleen responses, not for all patients, but almost all patients were getting very impressive symptom reductions. We've just started our first patient on this drug, so I have no huge experience, but it does seem to drop the platelet count. So in my next breath, I tell you, this is the drug that they want to test in patients with ET. It will be the first time we've been testing a new drug properly in ET for quite a long time. Then the P53 pathway, MDM2 inhibition, also being tested in myelofibrosis, both by Kartos and also by Roche. And Roche will be also testing this drug in combination with another strategy. And then lastly, BET inhibition. What on earth is a BET inhibitor? Silly three-letter acronyms. So it's very important in a number of different pathways. It's important in terms of immune signaling, in terms of down-regulating some of the impacts of the common cancer genomic pathways that are involved in cell death. And also it targets genes that are important in fibrosis generation. So this drug has been tested alone and in combination with ruxolitinib, and will be tested in patients with ET. Really interestingly, this drug is being used in combination with ruxolitinib up front. So this is the first time for a while that a company strategy has been, let's see what we can do up front rather than wait until a patient is failing. There's a couple of examples just to talk you through down here. Let's look at this one here on the right. This is a patient with a really high platelet count treated by John Mascarenhas in Mount Sinai. This patient had a good hemoglobin, which didn't really drop with the drug, but the platelet count has pretty much completely normalized. And this was the patient that made them think, well, should we be testing ET? So there was a lot of discussion. And the other action of this drug is illustrated on the left-hand panel. The orange arrows are transfusion events for patient. The green line is the hemoglobin, which has improved without transfusion. These are only 2 patients, but the trend looks very exciting for this agent. It's oral, it seems to be very well tolerated as well, which of course is really important. With a lot of talk about cell death, and the technical term for that in medicine is apoptosis. And this is another agent more commonly used actually in its sister drug, venetoclax, has recently been approved for acute myeloid leukemia. and really delivering very dramatic benefits for patients in that setting. So we're testing navitoclax with ruxolitinib in myelofibrosis. Very striking results for patients. And again, this company will be moving up front. So I think it's really exciting. We're going to start to test what strategies can we use to be better than ruxolitinib for patients. Again, this is an oral pill. Again, it will be presented at the ASH meeting. For those of you who want to watch updates at ASH, there will be an oral on this. So in summary, for myelofibrosis, there's a lot of different drugs, both alone and in combination with Rux, and probably also in the future with fedratinib. I think there are some big ethical issues that we could discuss in the panel discussion about discontinuing ruxolitinib, and some patients in some countries have run into huge problems with that. Because if you stop ruxolitinib, you will get a rebound in symptoms, you will get a rebound in spleen size, and the medical community, that is not included in guidelines, and the medical community is not always aware. It's not even in the package insert for the drug in Europe. It is in the US. So, some simple gaps remain, as always, like Stefan knew. We think we know more, then we realize we know less. We know more, but about the actual amount to know is even more. How many patients there are in a given region, what treatments are used, how the patients are doing, real-life data is really important. And then I was really pleased to see this figure used because we're thinking the same way. This is the myelofibrosis target that Stefan spoke through, wasn't it, so nicely earlier. So we've really to bring our communities together with pharma and also the payers, so the FDA and others, to really say what is the important question for the community. So I think that's it. Thank you. And I suppose finally, just to acknowledge that nothing that gets shown here isn't done without masses of teams of medics, of pharma companies, of research teams, and also patients who take part in clinical trials. And that can be really tough, and I think we're probably going to discuss that in a minute. So.
Claire, have a seat. Thank you very much. I am surprised. I was diagnosed in 2013, and my doctor said he's waiting for one medication which would be fine, and that was ruxolitinib in 2015. And we had only 4 medications at this moment. Yeah, we had anagrelid, we had aspirin, of course, we had interferon and ruxolitinib and HU. Yeah, that was all. And now I remember when I first met you, it was in Belgrade in 2016, and we were in the same bus to the hotel, and I asked you... I hope
something embarrassing isn't going to come out now.
No, it's great. It's great. And everybody was asking, how is ruxolitinib working in future? And you told me you would be glad if you would have 10 more years to experience it. What's your result now? It's 2015, 2019, and I think it's a major player, ruxolitinib.
Yeah, so I didn't want in any way to downplay the benefit of actually our current drugs, as well as ruxolitinib. I think that we made a lot of advances, but you asked me to speak about new treatments, so I was focusing on that. I have still many patients that were treated in the COMFORT study in our hospital on ruxolitinib. One of the issues is trying to work out when would be the best time, if there is a need to change that treatment for a patient. And especially if that change is associated with uncertain benefit. Adding another drug may add more risks, will take more time for the patient to come to a hospital, maybe have painful procedures. In the clinical trials, and what you might see written in press releases is a patient's average response is 3 years. In my experience, that's just about a trial endpoint, what percentage the spleen does. I do have patients who are shorter than that and also longer than that. I think ruxolitinib will still be a very important backbone, or indeed any Jak inhibitors. We learn again from our community in CML. They have several different drugs that target the mutation and the downstream effects of the mutation. And we often need different drugs. Patients will tolerate them in different ways. Pacritinib, momelotinib, fedratinib. Hopefully we'll have all of them available for our patients. They each have different benefits.
But it's important to know for us that the world has changed. There are many medications to come now. And that's a reason for us for hope. For we had in the last year, we had Besremi, we had fedratinib, and it will come to Europe, it will come to other countries. That's what we hope. And what you showed us, there's much more in the pipeline. Okay, are there any questions down in the audience? Felice, please. Press the button.
Relationship with the CML. We stopped treatment, and you talked before about the fear, the problem for patients to stop treatment. But how the community is, as a patient advocates, help you in the clinical trial to address the problem, to stop Jakavi, to lock what happened?
So I learned from Giora in a meeting last week about the impact of stopping a TKI for CML patients and about the withdrawal that some patients get, bone pain, etc., and also anxiety around stopping treatment. But actually, if you don't educate the clinical and the patient community that a patient who's stopping ruxolitinib, if you are not aware, the patients can die of stopping ruxolitinib because they can get a huge increase in spleen size and a big increase in their cytokine or chemical levels, which is like having a really massive, overwhelming septicemia. It's probably exaggerating to say that patient will die. Most patients are fine, but they do feel unwell and they do need careful monitoring, and they need to know what things they should report back to their doctor. So I think the patient community in the MPN field should, and indeed we do, when we start a patient on the drug, we say, don't suddenly stop taking it. But of course, something you were told maybe 5 or 10 years ago, you don't always remember. So we do have to do a lot of education about that. It's very tricky.
Are there some more questions? No, not at the moment. So we go on with the next point, and it's a panel discussion.